event is very useful to all our residents. So shall we start? So I think we need to make it more interactive, because this session is not a one-way kind of one way of lecture kind of things, but we will continue. And meanwhile, residents who all are there, I saw a couple of numbers are already there, and I think few of them will be joining. So any resident can interrupt in between, because we have 1 hour session, so we can have a question and answer session in between also. So this will be a more kind of an interactive session. Is that fine, Dr. Pikal?
Absolutely.
Yeah. So today I think this is one of the important topic that I think SSN team has identified on for a urologist. Myself, as a head of the department, now I'm associate professor at Department of Urology and Kidney Transplant Surgery at Teaching Hospital. Many of our residents will be interacting with you during your posting, and I think this is very important topic all the general surgery residents should know about. So actually, when a patient, most of the patients, when we see them in a OPD, so when you are in a OPD, they come with the complaint that they had a urine mixed with blood. So what they call as a very frightening symptoms. Some people also say that is a bloody urine, so or red urine. So these all are synonymous things for hematuria. So in most of the cases, when the patient notice that something is mixed with their this red coloring agent, most likely people, all the patient know that it's a blood when they had a red urine. So they come urgently to our clinics. So they will see the hospitals, because most of the things, this condition is very frightening to them. So my one question to the resident, so if someone asks you whether the hematuria word is a symptom or sign, what do you say? So any resident from your side? So I think they can unmute themselves. So any resident, they can volunteer, or shall I pick one from you? There's no answer from your side. Yes. Yes. Is it a symptom or a sign? So I will tell you, when the patient come with a red urine or a bloody urine, that most of the times they are considered as a symptoms. But when you send the patient's urine, or when you during your round, when you see the your catheters or the urinary bag with the red color of urines, when you identify, they are considered as the sign. So especially red color urine is the symptoms. But when you talk about the hematuria, it's all about the doctor who identified that the patients was supposed to have a clear urine, have some RBCs in it, or when the doctor see during the round that the urovac is filled with red urine and the patient does not notice about it, then that is considered as the sign. So hematuria is typically a sign that usually doctors find it. So when you go to the rounds and you need to see the Foley catheter, Foley's urovac attached with the patient side, sometimes the patient might have a general abdominal surgeries, but still sometimes you see this, can find this kind of color. So when you send these patients, the patient can have a traumatic urethral, traumatic urethral Foley's catheter insertions during the operation, or the patient can have a bladder injury, or the patient inevitably can have other pathology that exacerbates during your treatment. So you also need to see these kind of urovacs that may contain RBCs, and you need to investigate those patients. So I would like to specifically mention this saying from the Sir Robert Hutchinson, is that he rightly said that the ghost of dead patients that haunt us do not ask why we did not employ the latest fad of clinical investigation. they ask, why did you not test my urine? Because this carries a lots of significance while you are treating the patients. Examination of the urine is very essential to know the undermining sinisters. You can find so many um, diseases that is related to urinary system by just examining a urine. So what is the definition of hematuria? So we all know that hematuria is defined as the presence of RBCs in the urine. That is significant, but it's always difficult to label them as a hematuria, because my one questions to the resident, they can unmute themselves and answer. Uh, so does normal individual excrete RBCs in urine or not? So any resident? So I saw there are already 42 participants are there. I think many residents will be there. Any third year resident, they can answer this question. But typically, can the resident who are participant, they can unmute themselves or not?
They can unmute, and somebody has answered yes as well in
Yeah,
chat.
okay. In a chat. Okay. Anil said that he usually no. Take say yes, yes, yes. There are so many yes. Okay. So I will also keep this chat aside so I can communicate with them. So I think this is another a good way to communication. So Sachit said also yes. So I think the answer is yes. So we know that around 1,000 erythrocytes in every ml of urine excreted. When the blood is filtered in glomeruli in the kidney, most of the times these cells will not get infiltrated into the system. Only the plasma they will be passing through, but few of these erythrocytes will pass these barriers and they will be excreted in the urine. So now if the normal patients normally individually excrete RBC in the urine, so what is the its cutoff point? So anyone can guess. So I think Arun Shah said that less than 5 is normal per high power field. Yes, because I will also like to know, the residents should know about the processing of this urine for evaluation of hematuria. I think this is also the common question they will be asked at times in the examination, that how this urine need to be sent for hematuria, how the laboratory, our technician or our doctors will process. So whether they will see centrifuge samples, which part of the centrifuge sample need to be excarded and which need to be seen. I think this is a kind of a homework to you. So you also need to go and see. Many of you have already answered that less than 5 is normal. So when you talk about the hematuria, I think uh, the criteria is different for male and female, because female usually they have a polluted urines. Most of the times the female can have a few more RBCs in a normal setting. So for a male, I think more than 3 RBCs is in per high power field um, on a 2 or 3 samples. So single episodes of number of RBCs is not considered as the diagnostic criteria for hematuria, because sometimes when you have, there are lots of false positive results can happen. There are situations where patient can have a high number of normally uh, the individuals excrete normal amount of erythrocytes in urine, and they can be picked up as a more than 5. So for a male, more than 3 RBCs in 2 or 3 samples is a diagnosis for as a hematuria, and for a female the criteria is set up to be 5. Uh, my another questions to you is that is all red discoloration of urine hematuria or not? So what's the opinion? So can I have some? I think Arun Shah said no. It's correct. So yes, no, because there are so many things that can give a pseudo hematuria. That's called as a false hematuria. So there are foods, as you rightly said. The answer is no. Obviously, you all have answered. So I myself has a experience. I'm not sure Beetroots is one of the antioxidant, and I had a juice of beetroots, about half a cup of juice of beetroots once, and I really surprised. After 2 hours, I was really terrified because I had a very red, dark red color urine. So food, blackberries, which contains anthocyanins, they gives the urine red discoloration, which is considered as the false hematuria. Drugs like rifampicin, we all know, pyridium, and phenolphthalein, these are the drugs, common drugs like anti-tubercular drug as rifampicin, they cause a red discoloration of urine. So you all should know about that. All red discoloration of urine is not hematuria, because you need to ask about the drug history. Sometimes you need to ask about the food, especially the beetroots and blackberries. So I think this need to be keep in your mind while you evaluating the patient with hematuria. Now, how to diagnose hematuria? So we know that the presence of RBC in the urine is called hematuria. So we need to diagnose it. We need to confirm that there is presence of RBCs in the urine. So how will you diagnose? Uh, Dipstick. Someone has rightly said at the dipstick. Urine REME, correct. So how in your hospital particularly, which investigation would you like to send? Is there any hospitals where the residents are doing this dipstick by themselves in the OPD or not? So at least in my hospitals, we're not doing this dipstick at the outpatient department, but we have seen in the West, yes, many of you rightly said that it's the urine routine and microscopic examinations. Urine microscopic examination is one of the things that confirms the presence of the RBCs. So if you look at this picture, these are the, how does the RBCs look like? You know, in the basic pathology, you have read about that. So any answers from the resident side? Biconvective, Santosh rightly said. Yes. So I've already told you that I'm not going to tell you about how this urine will be processed in the laboratory. That at least you should know about. So how the sample will be taken and how they will process. I think that is is another homework for you, because this may be asked during your examinations. So it's a biconcave shape, red blood cells. Someone has also rightly said that hematuria can be diagnosed by the dipstick also test also. So these have been in the West. If you work in a very developed setups, because all the patients in the urology department at the outpatient department, they will be processed with the dipstick, and they come with this report by the OPD nurse, or gave you the report about by the OPD nurse itself. So how the hematuria is diagnosed by the dipstick? Basically, it's a peroxidase-like activity of hemoglobin, which change color of the indicators acting to the degree and amount of oxidation. Okay, so if you look at these things, so they have a color coding for, like, this is yellow is for hemoglobin. Okay, so if you dip this dipstick, so the color can have changed from yellow to very dark green. So it's basically depending upon the number of RBCs, is a concentration of RBC that's give you the different color. So by this, indirectly, you can identify the things. So you can check. So when you do this dipstick test, you can check there is a reference color. So you can match the color and you can find out how much RBCs is present in the urine itself. But does the positive dipstick means everything that it's RBC or not? So I already revealed the answer, but I want you to know this. So does all positive dipstick test for hemoglobin is positive for RBCs, or there are other things which can give you the false positive result? Yes, you rightly said, Sachin said myoglobin. So any other things? So the answer is Heavy exercise, yes. Heavy exercise is one of the condition where the normally the RBC get filtered into the urine. So it's a normal physiological exaggeration of the normal physiological response. So actually there will be a hematuria, there will be a presence of RBC, but that will be just a normal exaggeration of the normal physiology, which will get corrected afterwards. So those today I think we had one marathon run today at Kathmandu, and those who are not in a habitual way, when they run, do the heavy exercise, so they can have a. Another answer is concentrated urine, yes, because even the normal physiological excretion give you a false positive result. So these all are heavy exercise, concentrated urine. Always they give you the high concentration of RBCs, which cross the normal limit, and you may need to you may consider it as a hematuria. That's why we need to have a 2 or 3 samples to claim or to diagnose these as hematuria. So basically, the positivity dipstick is also they identify the RBCs, presence of RBCs. But other conditions like the urine will not have a RBCs, but still the dipstick will give you a positive result. And those conditions are hemoglobinuria, myoglobinuria, and sometimes contaminants like a povidone iodine. If you someone asks you to give a sample, and if he gives you the samples which contaminate the povidone iodine, you had a bottle in a home which contains povidone iodine, and you collect that urine with it, and that contaminates with the iodine, that gives you the positive dipstick test. So I think you need to differentiate between them. Do you have any idea how you differentiate between these conditions? So if you have a suspicion of contaminations, you always can give another sample. Okay, that's how you can rule out the contaminants. Now, how about the hematuria, hemoglobinuria, and myoglobinuria? How are you going to differentiate between these 3 conditions? So any idea? So first is the microscopy. Obviously, yes, because you need to look into it. And if you find a RBCs, biconcave RBCs in the urine, it's always, if there is, yes, positive, the positive dipstick test is hematuria. So you will label them as a hematuria. So dipstick test is itself is a screening test in the OPDs. So later that has to need to be confirmed by microscopic examinations. So it's a dipstick test is not a substitute for microscopic examination, but it can be used as a screening tools. So if there are no RBCs in the urine, but still dipstick is positive, and there is a false cross reactivity, the possibility could be hemoglobinuria or myoglobinuria. So how will you differentiate these 2 conditions? So after, if you have a suspicions of there's a positive dipstick test, but there's no RBCs, so now you have to take a blood from that patient. So the blood can have a hemoglobinuria. The there can be have a hemoglobin or the myoglobinuria. So these 2 conditions can be differentiated by looking at the serum. So what you need to do is you need to centrifuge the blood and see the supernatant, the serum. If the serum is pink, this considered as a lyse hemoglobin. Okay. So they can have an intravascular hemolysis, and they can have a hemoglobin, so which might be excreting in the urine. So to know the diagnosis, differentiate between this hemoglobin urea and myoglobinuria, you need to take a blood, centrifuge them, and see for the pink supernatant. If there is no pink supernatant, then the condition can be myoglobinuria. Everyone got this point? Okay, if the dipstick test is positive with no RBCs in the urine, so the condition could be hemoglobinuria and myoglobinuria. These 2 conditions can be differentiated by examining the blood, especially the plasma. Okay. We also know that these 2 conditions are also the false positive dipstick test, because severe dehydration, strength exercise, we already discussed it. There were lots of answers already in the chat box. So I think the identified or ruled out after having second investigation after some time. So these two conditions can be ruled out. So yes, someone also mentioned, yeah, Dr. Digvijay rightly. Hello, Dr. Digvijay. So it's a long time we've been not seeing you. I think, are you within the country or you are?
No, I'm outside.
Okay, outside. Welcome, sir, once again. So I think pharmacomechanical thrombolysis, that's correct. He rightly said that this can lead to the red discoloration of urine. And this is a situation where you need to examine the blood to identify the conditions. So I
Yeah,
think
pointed it out
residents.
because I do it like 2 times a week, and always there'll be pink colored
Yeah,
urine bag. I have to tell the patient to expect it. I'm busting all your RBCs there. So
yeah, that's
अहिले
correct.
पाउने भनेको यही हो के
Okay.
सुडोमा यही पाउँछ अहिले.
Yeah, thank you, sir. So I think a resident during their consultation, this is the one conditions where you will be called. So you are a general surgery resident, and whenever there is a night, usually the routine microscopic examination said in different ward they come at the evening. So during the evening or the night time, the resident will be caught for plenty of RBCs in the urine. So patient was admitted for fever, so many other causes. In a gynecological, in a gyne ward, they have been evaluated as a urine routine microscopy for a PSC clearance or so many things. So they will call you for plenty of RFCs in the urine. Uh, I think these are many of you have said. And when you go and see in the bed, there will be 26 years old lady, and all other investigation will be normal. So what could be the reasons? So there are only one isolated plenty of RBCs in the urine. So any guess? So we have seen so many at times this condition. Yes, Khadka rightly said you have worked there, Santosh Dev, you said it. This is a just ask the one question to the lady when you are LMP. The most commonly answer is 2 days back, 3 days back, or I am having menstruation. So we call this as a polluted urine. So these conditions you always need to be in your mind. So this is a common phenomenon. You will be asked time and again in the medical ward, in a gynae ward for this condition. And I think polluted urine is one of the condition where you need to consider. So now our second question is how to classify hematuria. This is very essential when you managing a case of hematuria. So any guess or any idea? So how can classify this? We already discussed about pseudo hematuria and the true hematuria because yes, so Grossman microscope will visible and non-visible. Yes, so many you already know about it, and there is a significance knowing these two conditions. So we called it a true hematuria or a false hematuria. Okay, false hematuria is also known as the pseudo hematuria. So we can also classify it based on the concentration. So when the blood concentration of the which is very less, it's usually not seen by your naked eyes. Patient cannot recognize that his blood is mixing with urine. So his blood, its urine is mixing with blood. So when the patient do not complain about this red discoloration of urine, and when you send your patient investigations in the lab, and then the lab give you 5 to 10 to 10 RBCs in high power field, we consider that as a microscopic hematuria. So that is also known as the non-visible hematuria. So at times the patient will have a very fresh, very red urine, and they come with the complaint that patient having a red discoloration, that we need to confirm it that there are RBCs, but still we consider that as the gross hematuria or the visible hematuria. So visible and invisible hematuria, they have a significance when you evaluate those patients. Okay. Another thing is that we classify based on the association with the pain or not. So what are the implications and what are the implication of these two classification, painful hematuria versus painless hematuria? Any idea? So I saw Navin said etiology, correct? Sachit, Dinesh, Santosh, they are replying most of the times. painless associated malignancy, once to it, yes. Benign versus malignant, they rightly said. Usually painful hematuria are associated with stones and infections, and they are considered as the benign most of the times. So when they have a hematuria with associated with pain, you need to consider that these conditions are benign, usually either infection or the stones. Or at times, patient can have a hematuria. I will give you a situation. Patient is having gross hematuria, and also patient is having pain, colics. So can the patient have a malignancy or not? We say that most of the painless clot colic, rightly said. So when the patient has significant bleed in the upper tract, that bleeding, usually this, when there is a the amount of blood that is shed into the upper tract is very low. They usually urine dilutes that and the clots will not be formed. When there is a gross bleeding or the massive bleeding in the upper tract, usually the urine will not be sufficient to dilute them and the patient can have a clot. So the massive bleeding in the upper tract can lead to the hematuria with the clot colics, and still the patient can have malignancy. So it's not a rule that painful hematuria is always benign. So sometimes the painful hematuria can also be malignant. But you always need to think that when the patient has a hematuria and the patient doesn't have a pain, now you need to think as at a sinister, because you can't leave that patient without proper investigation. So you everyone got this point? Okay. So there are also classified systems. Some said that it's as a glomerular versus non-glomerular hematuria. Basically, they are to differentiate it between medical hematuria or the surgical hematuria. Okay, so these are used by the internist most of the time. So whether the hematuria is glomerular or non-glomerular, because most of the medical conditions like IgA nephropathy, MPGN, FSGN, Alport's, membranous glomerulonephritis, they can have a glomerular hematuria. Whereas this non-glomerular hematuria can be medical or the surgicals, and the medicals are usually because of the drugs and other side effects from the medical conditions like papillary necrosis, renovascular disease, exercise-induced and anticoagulant therapy. And the surgical hematuria is, I always said that the mnemonics for SIT. Okay, so the SIT causing hematuria is a stone, infections, trauma, and tumor. So I think this is very easy to understand. So anyone had to add up on this fact? Usually glomerular hematuria, they originate from the glomerulus. So RBC has to travel a lot. So there are lots of diagnostic criteria out there that we'll discuss later. So if you all understand this point, so I'll move ahead. So how to differentiate between these glomerular versus non-glomerular hematuria? So any idea? One, with the nephrology will deal about this glomerular or microscopic upper tract hematuria. One is, yes, you can differentiate by the seeing the shape. Rightly said, cast, there will be RBC cast, so the dysmorphic, because the glomerular RBC is the source is from the glomerular stab itself. So it has to travel a lot. So while the RBC reaches to bladder, it's already this shape gets dysmorphic. Okay, there will be a change in the shape itself. So another thing is color. So let's see. So one thing is that glomerular RBCs, the hematuria, you usually see the cast. While in the transit is so long that once these RBCs get into the bladder and to the lab, it's already lose its architecture and only the cast are seen. Usually in the conditions where the patient will have hematuria in the medical conditions, they are associated with a very high proteinuria. So you need to see the protein also. Surgical hematuria, the patient will not have a proteinuria. So you need to see for RBCs, these glomerular hematurias, these RBCs are dysmorphic. So if you see these two photographs, the right and lower one is a normal RBCs, biconcave, normal shape is maintained, while the dysmorphic RBCs are varied, their shapes are various, and sometimes you can only find a cast. The condition like edema and hypertension are present with glomerular disease. And if you see the creatinine, okay, level, sometimes the patient already will have lots of glomerulonephritis. They already had a high creatinine with 2 or 3. Sometimes they might have a significant raise in the patient who already will have a significant renal insufficiency. So if you don't find RBC's cast, uh, RBC's morphology is maintained, patient doesn't have hypertension, edema, normal creatinine level, with no proteinuria, I think the most of the times the condition is surgical. So if you look at the common causes, so you also need to know about the common causes when the patient will have hematuria. What are the causes? We already told you that the surgical hematuria, the causes are cyst, stones, infections, tumor, or trauma. Okay. So these are the conditions commonly encountered condition in the urology practice. And if you look at the top 5, so what are they? We call a cyst, but still T is the prominent tumor. Okay. So if you ask to enumerate the common cause for hematuria, it's always the tumor or the malignancy occupies the top priorities, or they are at the top of the list. Bladder cancer, kidney cancer, urethral cancer, prostate cancers. Okay. And in our context, the stones are microscopic hematuria associated with the pain. Most of the times, the infections, pyelonephritis, tuberculosis, that's common in our part. Even with simple BPH, patient can have a vesical piles and they can bleed and they can come up with hematuria. So these are the conditions. Now let's see. You see this elderly people, they're enjoying, so they have been having pack years for about 20 pack years. I know this should be the sign everywhere, but this is not the conditions usually. Even as a medical fraternity, we lots of our colleagues, they still believes, and sometimes we know the fact, but still we're bound to have these bad habits. So elderly patients, when they have a significant years of pack years of tobacco exposures, and when the patient has hematuria, what would be the conditions? What is the dictum that we all must speak up? I need lots of answer from your side. Bladder cancer, bladder cancer, bladder cancer. So we all know this dictum. It is nothing, but it is these conditions where the people will have. So it's very easy. Even the simple history, elderly patients who have come up for a painless hematuria, and we call it PPP. What these 3P? One is painless, I would say, tell you. When the patient come with hematuria, if it is painless in an elderly patient, it's second is paroxysmal. So usually the patient come to you with the history that I had this episode 3 months back. It was painless, but it subsided on its own. It happened for 2 days, then everything went off. Well, so I didn't come think that I need to visit you. So it's happening again, paroxysmal. So it's coming with the time and again with this some time duration. And third is the profuse. Usually they will have a profuse bleeding. Sometimes they come with clots. So usually you need to understand that it's the hematuria is painless. It's paroxysmal. It happens in some uh, time difference with some in between the patient will be totally symptom free, and usually it's profuse. So what are the evaluations or the investigation that you can impart on those patients who coming with hematuria? I think we already discussed about this urine examinations because this is essential to diagnose the conditions. We know that all red discoloration is not hematuria, and you need to confirm it by urine examinations. Santosh rightly said that it's a cystoscopy. Yes, so we'll discuss because in most of our urology practice, we all have our cystoscopy at now with the OPD setup. So we have a flexible cystoscope. We have semi-rigid, but still we are doing it in the regular OPD as an outpatient department. So Elderly patients above 40, if they come with the microscopic hematuria or the macroscopic hematuria, you should not let go away without doing cystoscopic evaluation, because the first and foremost thing for the painless hematuria cause in the elderly is bladder tumor. We also have a lots of radiological investigations like ultrasound, IVU, CT, MRI. Okay, so these are the things, and we'll discuss briefly about what are the things that we need to follow. What are the radiological investigations that we need to perform before sending this patient back home. So this is one of the published article in 1999. So where this Khadra MH et al. Has prospectively analyzed the 1939 hematuric patients to evaluate in a current diagnostic practice. So what they have basically recommended is that the patient who have elderly patients who come for a hematuria evaluations, they should not send home without having cystoscopy, and that should be combined with a radiological investigation like ultrasound and or IVU or CT, because back then they are talking, lots of people are talking about IVU, but now most of the centers, at least in a urban setup, this IVU has been replaced by CT urography. I will also discuss about the classical comparison between IVU versus CT urography also. But the gist of this paper is that those patients who have a microscopic hematuria, they should not be let sent home without cystoscopy or the radiological combination of ultrasound and CT urography. So if you see the prevalence of the disease in the patients who are having non-visible hematuria, which is also known as microscopic hematuria versus visible hematuria. If you look at these, you see that when the patient has a visible hematuria, the incidence of the bladder cancer is at least one up to 20%. This is very significantly high. So when you have to evaluate these two conditions, microscopic versus visible, I think the visible should get a priority, and you should have a high index of suspicion for the hematuria, visible hematuria. So this table confirms or tell you that when the patient has a visible hematuria, you need to investigate him thoroughly, because the conditions associated with the visible hematuria is usually malignancies. Most of them are malignancy. But when the patient has microscopic hematuria, then you need to evaluate. The incidence is little less. So there are so many other things that you need to evaluate, whether it is painful or painless. So now microscopic hematuria could be glomerular, or there might be benign conditions which are associated with it. But when the patient has a visible hematuria, you need to take it seriously. So ultrasound, which investigation to do it? Ultrasound, IVU, CT IVU or the CT urography. So what's the scenario for the CT urography for hematuria? Is it the best choice? So what's your opinion? Is it the best choice? I think Dr. Sanjay Shrestha said no. So what should be the sequence? So we said that when there is a hematuria, cystoscopy should be the first one to incorporate into your investigation batteries, because this can be easily done under local anesthesia, and they should be available at the OPD setup itself. So after that, I think the another approach we all should need to understand is the ultrasound is very easily available. They don't have a radiation exposure. It's very cheap. So I think ultrasound will get another priorities because if there are some microscopic hematuria, where if the patient has a renal stones for a young patient, I think ultrasound will get a priority. But for a patients who have a high index of suspicion, elderly patients, gross hematuria, I think sometimes it's beneficial for the patients to directly go into the CT urography. Otherwise, if you are doing lots of investigation, it will taking lots of time. So what's the scientific evidence for the CT urography? So is it economical or is it politics? Sometimes if the loving people is very strong, who are selling CT scan, they may come up with that saying that this hematuria is associated with malignancy and CT is one of the investigation will identify it. So you can save lots of life by installing the CT in every hospital. Is it possible? No. So it should need to be balance between your scientific evidence, economy, and politics. So let's see these publications. So which Lang, Ike et al. So it was published in 2002. It went back, but still they said that the computer, what's the role of computerized tomography for the assessment of microscopic hematuria? If we look at this data, they 350 microscopic hematuria patients were evaluated with ultrasonography, IVU, flexible cystoscopy, and other radiographic imagings. And they all were negative. And the patient was again resubjected with CT urography, and the positive diagnostic rate was as high as 45%. So he claimed that, so if you have a high index of suspicion in these patients, you cannot let the patient solely on the cystoscopy and ultrasound. Uh, I think this is one data where they have insisted that this evidence is pointing towards or going towards the CT urography. I think correct, the Digvijay sir has already said that in the absence of evidence, the industry will win. But also, the industry are providing us the good technological support for the early diagnosis, and we are saving lots of lives. So basically, we need to balance between the scientific evidence and what industries want from us. If you look this paper, so I think they are more in favor of doing CT urography because of this positive diagnostic test is as high as 45%. This review article has given you lots of papers which is published during 2006 to 8, 10, 11. So they said that this for the diagnosis of the upper urinary tract urothelial tumors, the sensitivity and specificity of the CT urography is extremely high. So sensitivity is up to 100% in few of the studies, but at least they are as high as 90 to 95%. So I think when you have a high index of suspicions for upper urinary tract urothelial tumor, that's also known as transitional cell carcinoma, if the patient has a gross hematuria and your ultrasound and other cystoscopic evaluation are negative, I think this is always necessary. The CT will give you a better idea about this diagnosis. When we compare this IVU and CT scan for the diagnosis of benign disease also, so the patients, we consider patient coming with a microscopic hematuria and they have a benign disease like stone disease. Even when they had a comparison, it's a way back, a long back paper, but at that time they have compared between the CT urography and the CT scan. It's a paper published in 2003. And they found that this significant difference was found for the detection of the urinary calculi by the CT. So CT scan is also equally sensitive for the diagnosis of benign as well as the malignant disease. This another paper published in 2007 also, they found that the CT was more sensitive than IVU for detecting upper tract diseases. It is 94% versus 54. So to sum up all these scientific evidence, we found that the CT urography is more sensitive and specific to diagnose both the malignancy as well as the benign conditions with the patients presenting with hematuria. Now, IVU is remained as a historical importance nowadays. But if you don't have the CT urography facility, at least you should screen the patients. Even the sensitivity and specificity is very low as compared to CT, but still it can give you lots of idea about it. Okay, so now I think there is no discrepancy in the urban practice when you are working in the referral centers. The role of CT urography has already surpassed or proved its existence over the IVU. So I think this is clear. This slide will give you the idea about the prevalence of the different diseases in which the maximum when the patient were evaluated with CT urography, when the patient has microscopic hematuria, the four and foremost, the winner of this list at the top list is bladder cancer. RCC is the second one. So the patient can have a prostate cancer and the upper tract stones. So these are the conditions. And still at the end, you see about 80% of the patient can still have a negative results. So don't you think so it's not necessary that all the patients who have the microscopic hematuria or the hematuria can have a significant disease. They can have. Sometimes in the elderly patient, the vesical piles, when they have obstructing prostate, many patients can come up with hematuria, bleeding. But when you investigate, everything will be normal. So even in see, 80% of the patient can still have a negative CT urography, but you need to screen. You should not miss any patient with the malignancy. So when you diagnose the patients early in their disease stage, I think the prognosis is very good. So doing the CT urography for hematuric patients with a high index of suspicion, I think you should need to make it a rule. So upper urinary tract urothelial cancer, the incidence prevalence is up to 20% in a CT urographic evaluation, and the stone is about 5%. So now the questions again is, so what do you think? So what do we have a scientific evidence for the CT urographic evaluations for the hematuric patient? Is it a best choice? But still we can debate on the economy and politic parts of it. But I think we do have a strong scientific evidence for CT urography. So you all agree with me, or do you have a different opinion? So I would like to see a few comments on the chat box. So I didn't see any comments. Over IVU, yes, Dr. Digvijay rightly said. Now IVU had become historical importance. I don't think for the last 5-6 years I've had order any IVU now, because we are still on a referral centers, and we are using CT urography for evaluation of all the patients. But this may not be true for all the practicing surgeons or neurosurgeons remote part of Nepal. They still only can have a CT urography, but a good radiologist and a radiographer, they can give you a good IVU reports as well. There is a question from Dr. Robin. Is there a role of MR urography? I think we have lots of scope for the MR urography, but that's not for stone, obviously. There are conditions where at times we cannot subject those patients for a contrast. So if the patient has a deranged renal functions, urography or contrast imaging cannot be done. So at times that non-contrast imaging also gives up lots of ideas. For soft tissue tumor, yes, there are role of MRI. Sometimes the radiation exposures, but doing a MR urography for these patients is extremely difficult. At least CT is very fast. For detection of the stone is very sensitive with the CT urography. And even if you need to see at least for a filling defect or something, non-contrast imaging also give you a good idea as compared to MR urography. I think MR urography holds the very little space in the evaluation of these conditions. So any more comments from your side or suggestions? If you still want to know more about this, I would like to go into this paper. There is a review articles on CT urography for hematuria, which was published in 2012. But still, they have a good consensus on this part. So what they have basically consented that in every, because visible hematuria should get a more priority. The basic gist of this slide is that visible hematuria should get more priorities as compared to non-visible hematuria, and elderly patient more than 40. So visible hematuria for more than 40, directly go to CT urography. Don't use your time to investigate with the ultrasound, non-enhanced CT, IV. anything else. Directly go with the CT. But the patients who are young and patient has microscopic hematuria, it's always better to first evaluate ultrasounds. If ultrasound is normal, again re-ultrasound, and at times you have to switch it to other modalities like CT urography in the later. So the gist of this slide is that visible hematuria should get priority, and in elderly, you directly, after confirming the hematuria, the common conditions that is associated with the bladder tumor, which you can diagnose with the cystoscopy, which is office-based itself. So you can subject the patient for cystoscopy, and for assessment of upper tract, if you find that cystoscopy is negative, you directly need to go with CT urography. We're almost at the end, so I think we already had covered around 50 minutes time. So I would like to give you some of the idea about these conditions. So what are the common conditions with you? The patient can have a hematuria in your regular practice in around 5 minutes. And I think this will be sufficient. This 1 hour time, I've been able to give you some insight into this topic. So when the patient has hematuria and loin mass, what do you think that the condition might be? So I need a few answers. RCC, RCC, RCC. Everyone said RCC, but this is the conditions if you send the patient for hematuria with the loin mass. Usually UTUC, you said it, but UTUC will not come with the mass unless it is very advanced disease. So initial the presentations will be the gross hematuria for the UTUC patient, but the mass, I think yes, it's RCC is one advanced RCC. Another thing that you need to consider is the ADPTKT. So these are all the cysts with multiple cysts in the kidney give you the loin mass and at times multiple hematuria. Okay. So this is a benign condition, but you need to consider this one. Hematuria with gross hematuria with the filling pelvic defect is yes, as Anil said, is UTUC that you need to consider. They can come up with the filling defect in the ureter as well. So what about hematuria with the ureteric colic? In which condition you will get these two conditions? Stones, yes, Dinesh. Sometimes the gross hematuria because of UTUC, okay, upper urinary tract urothelial tumors, they can give you. But most of the times when it's associated with the colic, it's a stone. Hematuria, dysuria, or micturition pulse at times. It's the bladder stone, okay. So when there is small bladder stone, they can have a dysuria, the pain at the end of the micturations when the bladder neck is get irritated, or the patient can have a micturition pulse. What is the diagnosis for this? It's the acute cystitis, sometimes hematuria, fever, frequency. Okay, so hematuria when the patient has fever, frequency, urgency, which is new onset recently, could be a bacterial cystitis. When the patient has a long term, these symptoms for months, it could be a tubercular one. So we already discussed about the role of cystoscopy. Okay, so let's give you a scenario. So this is very essential for you to know. So if someone has asked you to do a cystoscopy and if you saw this picture in your cystoscopic evaluation, should you take a punch biopsy to diagnose this condition? So should we take a punch biopsy? Would you do it a biopsy? Someone said yes. Someone said urine cytology for malignant cell. Santosh, do you need to urine cytology to diagnose these conditions when you already see as a visually see the growth, polypoidal growth? No, not useful. Yes, Sachit rightly said. Okay, this is one message that I would like to tell you. Never ever take a biopsy from this side. Why? Why you should not? May not be useful, sir. Santosh rightly said. Yes, why not? Small tongue would give you a diagnosis. So see, there is now the bleeding. One, you are doing this in a local anesthesia. If bleeding happens, it's very difficult to control. Second, seedling. Okay, so you are disrupting the malignant cells. So you are disrupting the cell. They can have a seedling at other side. Third is you're not going to remove the small punch biopsy, and this visual impression is sufficient to diagnose the condition. Okay, so we need to have lots of information is required to effectively manage the bladder tumors, which is not going to get it by punch biopsy. So you should not do a punch biopsy to these conditions. What rather you need to do is, at least you can send for this patient to have a ultrasound done to evaluate the upper tract, whether there is dilated or not, whether this mass is excluding the orifice or not. So second, my question is, when someone has done an ultrasound and you come up with this report, the bladder has shown already a mass, should you plan for cystoscopy to diagnose the condition? This is another situation. One, you evaluated the patient for hematuria and saw the mass, so you're not going to do the biopsy. So in second case, you coming with this imaging. So are you going to do a cystoscopy for this patient? I didn't see any answer. Do you do the cystoscopy to diagnose the condition? Not for diagnosis, but for therapy. Therapy, you are not going to do the cystoscopy. For therapy, you are going to plan for TURBT. Maybe not, sir. Okay. Some say yes. Why? Why yes? Prixcon, Dev, Kota. Dinesh, I already said. Cystoscopy, you have to, during the TURBT, you have to do. During the TURBT, first the part of the TURBT is a cystoscopy, full evaluation under anesthesia that is required. So now I'll ask you another questions. What could be the another conditions when you have these similar pictures, which is not a malignancy? Is there any differential diagnosis of this condition except bladder tumor? Clot, rightly said. Okay. Can radiologists differentiate between clot and tumor? How you can differentiate? Just let me, yes, one is by mobility, one position there. Yeah, everyone is saying position. A very good sonologist will ask the patient to turn and check whether that mass is falling to the gravity or not. Okay, one position. Second is vascularity, rightly said. Clot changes with position and the clot will not have a vascularity. So the good sonologist will give you the diagnosis itself. You don't need to do a check cystoscopy to diagnose this condition. If the radiologist, by their probe, they can diagnose whether it is a bladder tumor or a clot. So what you need to plan in both the situation is you need to plan the proper TURBT under anesthesia. So you should not fiddle the tumor under local anesthesia. Sometimes you don't need to do a check cystoscopy when you already your radiologist has confirmed a papillary growth in the bladder. Okay. So in the TURBT, what you are going to do it, you are going to completely remove all the visible lesions. Specimen need to be referred to the pathologist in a separate container, at least exophytic plot, underlying detrusor muscle, or additional random biopsy is required. And the histopathology reports, at least 6 different information is required from the bladder tumor, from the pathologist to know the conditions or to diagnose the condition and for the effectively manage the disease. I'm not going to talk to you about the bladder tumor itself, but these are the few of the condition and the tricky situation where you need to plan accordingly. Okay, so you are unnecessarily, you will bypass all the unnecessary steps during the management. So I think my conclusion for the today's topics on hematuria is that hematuria is really a frightening situation for the patient. They definitely would land up to you once they see the blood in their urine. Okay, they urgently seek medical attention. You should be able to evaluate the case and do proper referral or diagnosis and the treatment. So when you are a surgeon, sometimes if you're doing stuff with the general surgery practice alone, so you are limited to the GI surgeons, the patient may come with the hematuria, so you should know where you need to refer. Other times, most of the times you can diagnose the conditions, and if you are interested in the urology, you will start treating those patients. And the gist is that elderly smoker, painless hematuria, usually gross hematuria, the common cause are bladder tumors, and you need to exclude malignancy. before sending this patient to home. So I think this is what I would like to um, know about in the today's 1 hour class. So any questions are there? So I will be happy to answer those. So now I'll stop my slides. So any comments or questions that you would like to know?
There is a question from Naveen.
Okay. The classification of hematuria as before voiding, during voiding, and after voiding. How much significance is that? Okay, correct. This diagnosis of hematuria at the initial part of micturations, throughout the micturation at the end, I think this all is for the knowing the etiology and the organ from where the bleeding might have occurred. So this is usually for the hematuria from the lower urinary tract. So when the bleeding is from upper urinary tract, all this blood is going to mixed in the bladder with the urine. So most of the time, upper tract hematuria, they present with the patient will have a hematuria throughout the time. So all the urine will be mixed with it. So when the pathology at the bladder neck, usually patient complain of hematuria at the end of the micturations. And when the patient has a pathology, some form of tumor or the AV malformation at the urethra, usually when the patient has a urethral injury also, they can have a small clot or bleeding at the urethra, and they can experience the hematuria at the initial part of micturation. I think this classification during voiding or at the initial part of voiding is for to know the etiology or to know the sites from where the bleeding might have occurred. I think, thank you, Dr. Digvijay sir, for saying that I've covered most of things, but I have not covered much. So I have given so many homework also to let them know. And I'm ready. I have shared my email or phone number at the initial part. So if you have any queries, you can always come to me. So say thank you for your informative. I'm not sure this is not going to be in a 1 hour time. I'm not going to tell you all the things that is necessary, but at least I try to cover it, the basic things on hematuria, so which is essential for you to know. Dr. Robin is there. So Robin is working as a uro-oncologist, and he's the one who's seeing most of the hematuria patient. So Dr. Robin, any comments?
I think you have covered it well. I think the residents have really taken up your slides very well, I guess, and it will be very helpful during the exam time also. So I think I should thank you for covering it well, at least for the
So
residents,
I will
and then
request
how to go about it.
I will request the SSN executives, because I would like to first thank, because this platform you have created. So Dr. Digvijay sir, after so many times we get to although I'm sure he is in Delhi or in India, is not, but still we can join together. So I think this virtual platform is that you have created is a terrific platform for education and academic discussion.
At least we got him to say something, right?
Yeah. So SSN meeting we usually have at Kathmandu or the Dhulik Health every monthly CMEs, but we have been seeing only few of our cases that the surgeons are joining us from Kathmandu itself. But I think now this virtual platform we create, so we can have a nationwide participation as well as we can participate from anywhere from the world. I think this is one you have done tremendous job. So I would like to congratulate you and I would like to thank you.
Yes, it is all the combined effort, and I think we should thank Bikal also for this, to bringing about this great idea. So I think there are 44 residents, 44 participants, and I think it has covered most of the part of the country. So let me thank you, and then I think we should close the session.
Please consider me anytime. So because please let me know at least 1 week prior to that, so I have to arrange my time. So I'll be more than happy, because I'm in a teaching institute and I'm always happy to teach our resident. So please consider me whenever it is feasible.
Definitely. I think we should thank all the participants, all the residents. I think you have got most out of Dr. Pawan and Professor Pawan Salise. I think that will be very, very helpful. Thank you very much. Good night,
Good night.
everybody. Thank you. Thank you.